happy 12th night. Thank you for risking your own health and well-being getting to this meeting, and welcome to members of the Fact Scrutiny Committee as well, who are here for the first substantive item. Obviously can stay for the whole meeting if they so like. The first item is apologies for absence.
Chair, we have apologies from Councillor Carr, Councillor Hunter and Councillor Morris.
Anyone else that we know of? No? Okay, thank you. Do we have any disclosure of members' interests? Unusual at this committee, but always need to check. No, thank you. To note the minutes of the last meeting that was held on the 11th of November, which have been circulated, can I have a proposer that they're true record? And thank you, Councillor Smith, and seconded Councillor Oakley. Item 4, the Health and Wellbeing Board. The minutes of the Health and Wellbeing Board held on the 9th of October, which have been circulated. Happy for those to be noted. Yes? They're noted. Now, the first item, substantive item, is Northumberland Children and Adults Safeguarding Partnership, the annual report. And welcome Neil and Audrey, our children's and adults gurus, to present on this report. So over to, I don't know who's going first. Yeah.
I'm going first, Chair. Thank you for that. Yes, Happy New Year, everyone. Pleasure to be here today to do a quick whistle-stop tour, hopefully, through the abridged annual report. And I'll come on to why it's abridged in a minute. But I'm just going to start with a little bit of background, because I'm aware there might be some different knowledge bases around safeguarding within Northumberland and the kind of strategic framework around safeguarding. We're here to present the annual report on the Northumberland Children's and Adult Strategic Partnership. It's a statutory requirement for us to have safeguarding boards. We're required to have two, an adult safeguarding board and a children's safeguarding board. And about 2 years ago, we decided in Northumberland that we were going to merge the two. A very deliberate decision taken after actually a couple of years of consultation and thought process in it. The idea being to blend the learning that we get from the two boards. There were similar issues cropping up in area. There were different issues, but there were many similar issues that were cropping up. And for efficiency, we decided it would be a good idea to bring them together. So we did that about 2 years ago. And that has been felt to be a resounding success, I think. I feel Audrey nodding to our right-hand side there. We will constantly review that, but it has been felt to be a success. As I said at the start, it is a statutory requirement, though, and it's a statutory requirement on 3 public bodies. One is the local authority, one is the ICB as the health lead for the region, and the other is the police. So there is no getting out of that. Those 3 bodies have to come together and form the boards, and they have to promote safeguarding arrangements within the area, in our case in Northumberland, but within any of the areas where that operates. We have to drive improvement through safeguarding and basically review it from a strategic level. The lead officers are the chief execs of those 3 organisations. So that is Helen Patterson for the local authority, it's Sam Allen for the ICB, and it's Vanessa Jardine, the chief constable for the police. But they delegate that naturally down to lead officers to undertake the detailed work and to run the boards, etc. And it's myself and Audrey that are the 2 local authority delegated partners. It's Richard Scott, the Director of Nursing at the ICB, who handles the health side of things. And it is now, just recently, Kevin Waring's taken over, who's the Chief Superintendent Area Commander for Northumberland. So that's the context. As I say, it's a statutory responsibility. It has to happen. And if I flick onto the next slide, the annual report, it is also a statutory requirement that we report annually on what we've done around assurance in terms of safeguarding, around promoting its importance across Northumberland as an area, and we feed that back through the annual report. What you're getting today, though, is actually a 6-month report, not an annual report. Due to the changeover in merging the 2 boards, we got slightly out of sync in terms of the annual reporting cycle, and we wanted to bring that back to an April to April reporting period. So as I say, a slightly condensed version, an update to the previous 12-month report, and almost immediately, come the end of March, we'll start on the following year's report, and we'll get back into a full cycle that's slightly fuller. It has slightly more outputs and statistical figures in there and things like that, but this one draws out kind of the key things that have been happening within that 6-month period to reassure you, hopefully, that we have been having a significant focus on safeguarding within this area for both adults and children's. To get into some of the things that have happened over that 6-month period, and I'll pick up one of the slides and then Audrey's going to pick up a couple of them, around strengthening safeguarding arrangements. I mean, the top two there, what we're constantly doing in this environment is rechecking our protocols, rechecking our documents, rechecking the various practices that people are working to. And we did update our multi-agency safeguarding arrangements, the MASA. Apology, we are riddled with acronyms here. And Audrey has quite rightly said we're going to send out a revised version of this presentation to you with all the acronyms kind of played out in full there, so you can see the full names. But we've updated the multi-agency safeguarding arrangements, and we've updated the information sharing protocol. A lot of the purpose behind the updates of these, I mean, some of it is to tidy up issues that we spotted through serious incidents that have happened, but a lot of it is just to get paper back in front of those people who are dealing with vulnerable adults in Northumberland and reminding them how important safeguarding is again and again and again. There's members training for safeguarding as well. This training embeds out into all the other public bodies that are interacting with people. So primary care, hospital services, the police, the fire service, etc. We are constantly re-pushing the importance of it because we're desperately trying to get early identification of any issues. And there isn't a magic wand to this. You can't just bring in a solution and suddenly everybody will be safe. It is about an individual in somebody's home spotting an issue at a point in time and remembering that safeguarding is important and learning from the experiences that haven't gone so well, unfortunately, and that we've picked up and developed and reviewed things from. So the top two were a refresh of those things, and particularly the information sharing protocol is really important as well, that agencies need to be aware that where a safeguarding issue is unravelling, actually information sharing is much more important. So the police need to share information with adult social care or children's social care and vice versa, etc., and the health service. And again, there can sometimes be some uncertainty about that, so we develop protocols so that people can be crystal clear when they're allowed to share information and when they aren't allowed to share information. We had a bit of a review of membership of some of our forums as well. Although there are 3 statutory partners, it was within our powers to draw any other organisations into safeguarding, as we feel we need within Northumberland. And we have within our business group brought in the DWP and the VCS for a greater voice in the development of safeguarding initiatives and safeguarding practice going forward. So again, that was something new that was brought in during that 6-month period. We have as well, we had 2 business groups. We had one for adults and one for children. So although we had an overarching kind of strategic group sitting together and an executive sitting together, we still have the individual business groups. We've now merged those as well. Again, greater sharing of issues as they're arising, as we're getting learning from serious incidents that's unravelled. We wanted that opportunity to cross-fertilise that knowledge and information and make sure that learning from children's, as far as possible, is taken into adults and vice versa within those various areas. And lastly on this one, we have reviewed the frameworks for safeguarding adult reviews, and I need to check the acronym again, as Audrey was saying before, for local child safeguarding practice reviews. These are basically investigations of serious incidents that have happened in Northumberland. I mean, as an example, we were criticised a year or so ago for taking far too long to make a decision on whether a safeguarding adult review was needed in a particular case. So we've updated the protocols and the frameworks, and we now have a 15-day deadline. We will make a decision within 15 days as to whether a safeguarding adult review will happen in a particular case. So again, we're learning constantly, we're tweaking the guidance, and we're just making things a little bit better and a little bit safer for people. Audrey.
Thank you. Thanks, Neil. Happy New Year to everybody. Good to see everybody. Second day back in. So, as Neil said earlier, a number of key achievements, and these do only relate to the last 6 months, so a number of areas to talk about. And there are some real benefits here from having the children's and adults together. Our children grow up to become adults in the first instance. Sometimes the complexity of families means that we see this journey continue for some while, but also more than often when we are dealing with children, we're also dealing with adults because of the parental or the carer or a wider familial relationship. So really important, I think, that that combination of children's and adults is understood and recognised in terms of the benefits that we see. So I'll talk you through some of our key achievements. I was going to say this time last year, but probably a bit earlier than this time last year, Neil and I were doing the similar report and talking about the Sophia review, and that was where we undertook a review, and it was a child's voice, a very different way of undertaking that review, and we were hailed nationally for that. So actually we've continued using that work and gone out with some learning events, and that's a bit on the continuous journey. If you think about there was the challenge, the issue, the actual review took place, and then we take that learning on the road and we understand what that looks like. Because actually our practitioners learn from it, but not just us, but the region, nationally, other services that we link with routinely also learn from that. So to date, 300 plus attendees, really strong positive feedback, and our shame awareness training's been extended. So as a result of that, the development and request has asked for that to go further. So our exploitation and missing, and our PREM roadshow is another little acronym for you, so we will make sure that you get a glossary. But that's partnership reduction of exploitation and missing. So again, roadshows, significant numbers in 6 months here, 280 attendees. And as a result of some of this, the development, the work, enhancing everybody's knowledge, understanding, joining together services, we have seen some tangible reductions in our current statistics. So we've got 13% fewer missing adults, 16% fewer missing children, and our return home interviews have improved from 66% to 89%. So that, I don't think that can be underestimated, that learning and the development that's going on. Some policy updates there, some really good work around thresholds, and I see these ping in, so they come into all of the children's system. It's not just about a ping into everybody's email system, it is taking everybody through the work, through learning lunches, through regional development work, through some of our boards and networks and the subcommittees that Neil's already explained. So really, really important. A self-neglect guidance has been launched. We've aligned those local children's safeguarding practice reviews and safeguarding adult reviews. We've aligned the frameworks for that practice. And we have information sharing guidance for children's workforce, so that we're making sure our colleagues are staying within the guidelines and expectations that we are monitored and measured against, actually. So really, really important. Some great interactive dashboards. Everybody loves a good dashboard, but some really good ones have been developed. And that improvement around the coding. So again, nationally and regionally, getting some consistency, so we are all talking in the same language, because each different authority sometimes calls things slightly different. So each safeguarding partnership may name things slightly differently. Nationally, it's named slightly different. So that coding is really important. And actually, for members of our family and children's scrutiny, you'll have heard me talk about this from a SEND perspective. We're doing some work regionally around that coding and the nomenclature that we would call any kind of aspect. So really important. That way we are all ensuring we are talking about the same thing at the same time, rather than 10 minutes later realising, oh, that's a different bit of conversation. So really important that we understand that much more quickly. And of course, you will have read our Ofsted reports previously, so they like our quality assurance arrangements, our quality of practice work, not just in data, but more broadly around children's. We've extended into SEND, and we'll see that go further in the future. Our domestic abuse in young people, some great work going on there. Our task group, particularly around our young people, that's going to transition to oversee teenage relationship harm pilot work. Again, some great work across the region. There is also Tyne and Wear Northumberland Safeguarding Partnership, which is the Northumbria force in terms of safeguarding, and the team, and I'm looking to my right because the team are to my right, Emma and Sarah have showcased some of that work across that Northumbria force, and Northumbria, of course, have worked with us very clearly on that. Sam Rennison is the previous chair, and Superintendent Kevin Waring coming in as the new chair. So some really good work there. And then, of course, we share our domestic abuse specialist with North Tyneside. And so we've already had a collaborative event with North Tyneside, really thinking about interactive learning and how we could do much more with that, and some really strong positive feedback. And then last but not least, in our key achievements, our Safer in Education subgroup, big focus around electively home educated, growing cohort that we are going to do some more work on in Northumberland, but already reviewed the strategy, really strengthened that. We've got a local definition around educational neglect agreed, and protocols for concerns about safeguarding standards, and the designated safeguarding leads. They have been implemented to make sure that they are really clear. When a child leaves a school register and becomes electively home educated, how are we alerted to that? How do we ensure that we can stay on top of it and make sure we do our statutory checks? More to come in the future around how much more we may do around that too. Of course, what we don't just talk about are our key achievements, but we are always very open around our challenges and emerging risks. So naturally, we've talked about, we share together, we look at that work and say, oh, actually, what's happening in children's, what's happening in adults? Are we seeing some patterns, and what could we do about that? Does that change our self-assessment around the work we need to do in the future? Does it mean we have to have a greater focus in one area and less of a focus if our statistics have reduced? Is that a pattern we're seeing? And so really important that we have a look at some of our challenges. So we are seeing some pressures in safeguarding teams. Not least as a result, we've got some significant changes coming up with our children's social care reforms. But they will strengthen over time. But of course, whilst you're moving towards that, it gives you significant pressure because it's developing the new reforms as well as dealing with the work that we've got. And it would be remiss not to mention that our colleagues in the Integrated Care Board across the region are also undergoing some significant restructure and challenges. And that is causing us as an authority, as it will all my fellow authorities in the region and across the country, some challenges too. Face-to-face child protection conferences, they prefer face-to-face by families, but quite often they're really hard to implement face-to-face, not least because we're such a large rural county, bringing everybody together and getting that capacity into all of the different places. You know what I'm going to say, do we try really hard to make sure that we do that every time? Yes, we do. But it's a real challenge and it's a risk for us. I wouldn't want to sit and say we will do all of those face-to-face every single time, and hence we've added that onto our challenges list. Elective home education, I've already mentioned that one in terms of our achievements, some really great work there. But we are expecting a new white paper that will come out spring, I think is the latest. It was going to be New Year, it's now moved from New Year to spring. So it will emerge hopefully in 2026. I don't know whether there will be anything specific around EHE in there, but there is certainly a significant rise, and it is without doubt linked to the rising number of exclusions within school and the rising SEND population. So we will start to see in Northumberland how we look at this very, very differently. And no doubt throughout the rest of this academic year, there will be something that comes into family and children's services where I want you to have your view, perhaps even a task and finish work group that we can take a look at that. Complex mental health, again, and you've heard me say this before, and Neil in many of the reports, but that task group, we've got a delay in progress. We really need to think about aligning that work with some other work streams so that we can get some traction and some progression in that. And it's not just that it's NCC who's part of that group. We actually need the wider services because we don't deliver the mental health service area. So we've got to have the prospective professionals and expertise to be able to have that. So we need everyone to come to the table to do that. And then looking at exploitation trends, links to vaping and railway networks, we have identified those as emerging risks. So seeing continued rise in vaping, some real challenges health-wise that Jill's team talk about in terms of their annual report. But we have some additional rail networks in Northumberland and we already have a number of aspects where we've seen some real trends around life-changing decisions being made by young people around railway networks. So we'll continue to have that on our radar moving forward. Thank you. I'll hand back to Neil.
Thanks, Audrey. Okay, just a couple more slides if that's okay. There's a little bit more detail in the report itself, but I just wanted to give you an idea of size and scale in monetary terms of the operation of NCASP here in Northumberland. So the budget is about £350,000 and contributions come from the 3 statutory partners. So that's the local authority, the police and the ICB. In the middle bullet points there, I've just given a little bit of an idea of the scale of spend in different areas. So there is a slug of that on staffing, which is the core team that supports us with strategic safeguarding, and a little bit of admin linked to that as well. The vast bulk of the spend out with the staffing goes on training though. That's training programmes, as I say, not just for the local authority, but right across all the partner bodies and wider, that we feel is needed in order to get the word out about effective improvement in safeguarding arrangements across this county. There is an allocation there for reviews if we need to take rapid reviews or adult safeguarding reviews or the children's safeguarding reviews for significant cases that we feel need investigation. And it is a statutory requirement that we have a scrutiny lead independent of any of the public bodies that are involved within the running of the partnership. So there is an allocation there for a couple of days a month. I think we have Sue Kirkley as our scrutiny lead, and she keeps an independent eye on us and will critique and write reports and feedback on what we're doing and whether she thinks that's within the parameters of what we should be doing as an organisation. There is a bit of regional work going on at the minute around cost sharing. This one's tricky for the police and for the ICB. It's easy for us as a local authority. We are Northumberland and therefore we're only responding to Northumberland, but the police are obviously operating over a much bigger footprint as Northumbria Police and multiple local authorities, and the ICB has an enormous footprint that goes right down to the Tees area. So again, when they're looking at contributions, they've got to feed all of the safeguarding partnerships in all of those areas. So there's a bit of a review going on about that at the minute, and we'll see how that unravels over the next 12 months. But we need to make sure it operates effectively here in Northumberland. And then probably the most interesting bit when we come into these sort of forums, and the bit probably we're most interested in feedback on as well, is what we're looking at the minute and what we're planning on looking at going forward. And remembering we're only 3 months away from the end of a cycle here, so we will be refreshing what our strategic priorities are for the safeguarding partnership. Again, any input either in this meeting or if you wanted to send it separately afterwards would be helpful. But the key things that have been exercising of us over the recent past and currently are, as Audrey said, the exploitation issues, adults and children's exploitation, and the various responses, training and background that we're trying to put in place for people to be able to spot those sort of things and for us to get early identification of issues. Complex mental health we've talked about as well, particularly things related to trauma and trauma awareness, so that staff are spotting that when they're interacting with people who've been through significant issues and incidents, and we're watching out for mental health issues coming out of that. Although some of the safeguarding work has been a little bit slower than we'd ideally liked, there has been a lot going on operationally though. Adult Social Care now has a severe mental illness team that they've built with CNTW as the main mental health provider. So there are things going on still, but we want the safeguarding aspect of that more widely kind of developed and people more aware of it to push out there. And then the other one that's still on our agenda and has been for a couple of years is neglect, and particularly self-neglect. I mean, over the recent period, the last 12 months or so, 18% of our more detailed deep dive Section 42 inquiries have been self-neglect now, and it has been a growing area, particularly since COVID as well, in certain pockets of society. We did have a burst about a year ago of single men who lost their wives in COVID, who were suffering significant self-neglect. So again, we're making staff aware of those sort of things. They need to be looking out for that when they're going into people's homes, and we just need that professional curiosity at really high levels so that we catch things early. Other areas for focus on the right-hand side, this can be a really difficult area to measure impact because we're often not dealing with very big numbers at all in terms of the outcomes. Thankfully, there are not many serious incidents. So when you're putting out swathes of training to thousands of staff, if the incidents drop from 2 to 1, what does that mean in essence? Is our training successful? So we're going to have a really good look and a deep dive at meaningful indicators to measure the impact that the training's having, because the headline stuff can be quite difficult to tell. couple of specific areas there that we're looking to push again. Transitional safeguarding, so children leaving care and disabled children coming into adulthood, and how we actually wrap safeguarding around that and make sure we get a good transition from Audrey's teams into my teams in particular from a local authority perspective, but then the wider public bodies as well. And safeguarding issues for carers, including, that should say, young carers, not your carers, including young carers, which is clearly a key area for us to pick up early as well. All local authorities had a ministerial letter a while ago around having a look at homelessness and rough sleeping in their areas. And we have been looking at that in Northumberland, and we're continuing to look at that at the minute. We're not seeing strong evidence of it being a significant issue for us in Northumberland. I suspect some of the inner cities will have a far greater problem with that. I mean, I used to live in York and I used to live in Oxford and used to kind of see that firsthand. But we're still having a look at that and just making sure we're fully aware of just how big an issue we think that is in Northumberland. And then a couple more within Audrey's world that she's touched on before, so the elective home education issue and child sexual abuse within families as well are two key themes that we're continuing to look at and explore. But again, what's really interesting, if there's things that you think are missing from that list that you think are important, either within your wards or within Northumberland, or you think we've got some of that wrong, I mean, that's helpful feedback for us to get, particularly now as we're starting to have a look at the next 12-month period and what the priorities will be. And I think that was it. Thank you, Chair.
Thank you very much. So the Children and Adult Services team in this council, and there's a lot of evidence, perform very well, and safeguarding performs very well, but there's always room for improvement, even from a high standard. And the nature of what we're talking about, if one adult or child has failed or misses, then that's obviously one too many. So please dive into this, and I'll open it up to any questions. Councillor Green.
Hi, thank you, Chair. Regarding the elective home education, do the children still take key stage tests, and how do we identify educational neglect?
So yes, they do. They can register at a number of schools around Northumberland. Our statutory duty is to ensure that they are following a curriculum, and we can do an annual check on that basis. While we do the annual check, of course, you would expect the teams to be well trained, well informed, and using the opportunity to look at the widest sense of what we would call contextualised safeguarding. So it's not just about neglect, it's absolutely everything that we would consider when they're visiting. You know, part of my development will be how do we see much more of that. The very nature of some families are that they choose to not engage as much as we would like them to. And so it's really important that staff are fully trained. As Neil said, the significant amount of monies that we spend is on training to ensure that we've got staff in the right place to be able to look at that and do that identification appropriately.
Thank you. Councillor Oakley.
Emma, do you want to pick up on that? 'Cause we did. Sorry. I'm looking at Sarah and saying Emma.
There's in particular domestic abuse in teenage relationships, so it's part of contextual safeguarding and risks outside of the home. Domestic abuse, members will probably know, domestic abuse, formal victims of domestic abuse can be from 18 plus, but we recognise that more and more relationships are becoming domestically abusive in their own right. We know from Holly and Hexham, for example, that kind of situation. So we've got unhealthy relationship work that's going on across all of our services and in schools, but it's about those specific circumstances where there's a risk of harm because of those relationships. So what we've done in Northumberland is we've come up with a definition which has now been adopted by the regional colleagues for that to then come in. So we had a similar pilot around children to parent violence, which were mirroring for this. So there's a process that comes in that's part of the CCNs from the police or notifications. Oh, sorry. I normally shout loud enough, don't have people to hear. Because we don't really know what the prevalence is. We don't, people were recording it in a different way in different services. Schools weren't sure what to do. We weren't sure what services were there to support it. So this is our way of kind of finding out what the prevalence is and how we can then support those children. So we do have an update that we've just given at a regional conference that we can share the link for people, and that'll give an update on the numbers that we're seeing and also the process and how that's working. So it's a really dynamic process, and we're all evolving it as and when we need to, and we're also getting the universities involved, of course, to help us evaluate that. And the region is sort of trusting us to kind of share that learning, and they're going to be developing services in other areas based on what we're finding as well.
Just to remind everyone, obviously could hear you, but the meeting's recorded as well, so it's the benefit of, so just if you're asking a question or answering, no, that's fine, we could hear you, but it just for the benefit of the recording and people watching back, and anyone who is a bit hard of hearing. Does anyone else have any questions? Mr. Bird?
Good afternoon, colleagues. Thanks, Audrey. Thanks, Neil. Good presentation. Simple question. Can you share those slides? Colleagues may find them informative.
Yeah, we're going to get the acronyms all played out and then we'll share them. So yeah.
Appreciate it. Appreciate it. Thanks, Chair.
Councillor Austin and then Councillor Smith.
Thank you very much for your report. Could I just make a very, very simple request? That's instead of just having percentage numbers, actually have the underlying numbers. Are we dealing with 2s and 3s of people, or is it hundreds that we're dealing with? That's my point. Thank you.
Yeah, when we do the presentation, we'll put you the numbers in as well as percentages.
Thank you very much. Thank you.
Councillor Smith.
Yeah, thank you for that report. I'm going to ask something about what you mentioned before, complex mental health needs. I think we're all aware of the tragic events in Teesside a year or so back. 3 girls committed suicide within one hospital. We're also aware of issues like Valdo Calicade. A guy was referred to the specialist mental health team. They discharged him back to his GP because he wouldn't engage in therapeutic intervention. He said, nothing we can do. The guy was a homicidal, paranoid schizophrenic. Locally, we've had people like Odessa Carey. I don't know if anybody's aware of the lady who chopped her mother's head off and carried around in a shopping bag. What do you do with people like that? And my impression at the minute, and I'll certainly be correct if anybody differs, is that we are geared towards a culture and an ethos where it's right risk assessments, right care plans, have meetings, document meetings. But on a day-to-day basis, what do you do with someone with this severe, intractable needs? And you just think, I can't get through this burst. Some people are untouchable. But again, I think we're in a culture of you get allocated these persons, a care worker, mental health nurse or whatever, and it's like, cure this person, but you don't know what to do. And I think there's also a danger of burnout among practitioners because they get dumped with severe complex issues. A lot of people come in this job are trained up to writing paperwork, but they think, I don't know what to do here, and they get burnt out, and consequently the rate of churn is much higher than it used to be as well.
I mean, that takes us into a whole territory around dealing with individual cases there. I mean, clearly the report today is about an environment for identification of issues and early targeting so that we get cases allocated to ideally the right resources to be able to help people with their situation. What I would suggest possibly if we wanted to do a deep dive into the kind of what happens next on a live case, I mean, a lot of what we talk about here is learning from cases that tragically have gone wrong and things like that around early identification. It may be worth a sort of a joint session with CNTW and the local authority potentially on solutionising issues around individuals with complex mental need and challenging behaviour, rather than starting to go into that. You'd want all the experts in the room to be able to talk about that, and I suspect for you to be able to challenge that appropriately, because as I say, we're moving into slightly different territory from safeguarding there.
We are planning a piece of work on mental health, and which might be more detailed than just one report. And Jill, you're actually producing something which is such an important, so thank you for raising it, it's so important. Do you want to say something about the piece of work that you're currently doing?
Yes, certainly. On behalf of the system, we're coordinating the adult mental health strategy for Northumberland County Councils and wider partners. So that is an area that we're hoping Overview and Scrutiny will participate in as we develop that. Now, whether or not that covers the specifics and the nuances that Councillor Smith is alluding to, then it may still warrant a separate conversation about complex mental health cases.
It might be worth, could we have a draft report and then people could feed in, because there's different aspects to it. So we could have a draft report and then feed in if there's other areas and further work that we need to do, because it is a really important issue. And anything, I mean, you always have, and we'll get on to this at the end, anything that people want for the work programme, but if anyone has got, email myself and Rebecca, if anyone's got an aspect, I know we're going to be looking at X, but could we make sure we look at Y, just so please feed in all the time ahead of the, as we're developing the work programme and specific reports. Does anyone else have a question? Councillor Oakley?
Hi, we were talking, or you were talking about the high level of exclusions, and I know that I think SEN children are more likely to be excluded from a mainstream school, but I also understand there's academies. Is there any way, and there might not be, that the local authority can influence academy trusts to be more inclusive, so that children aren't being excluded?
So we would hope most children are included in schools. We do know that what we have are rising exclusion rates, although we have seen some decreases in that in Northumberland. The most effective way to ensure that children remain in school is to ensure that their individual needs are met. Sometimes that's around SEN, sometimes it's not, sometimes it's behaviour that is potentially wrongly labelled as SEN. I haven't had any phone calls so far today actually, or yesterday, but the new inspection framework has a significant change around inclusion, and I think it will be really interesting to see whether or not that new inspection framework that holds schools to account does have a difference, and we will be measuring and monitoring that from now till the end of the year. We'll be able to measure it against last year's exclusion rates and the previous years, and so we'll be able to have some empirical evidence as to whether it does make a difference, but all schools will be measured against that inclusion standard within the new inspection framework. So I think that's probably our best chance. Each school, we devolve, as a local authority, we devolve responsibility and accountability to head teachers and governing body. That's the leadership. But there are some expectations, fair access panels. We have some routines and consistency across the whole county. And actually we're beginning to do that across the whole region, and brought together a number of our multi-academy trusts regionally, those who cross borders of different local authorities, who perhaps have schools in 4 or 5 different local authorities, and we're bringing them together to get some consistent approaches, because actually a number of CEOs are very vocal and strong around they want the exclusion rates to drop as well. So hopefully we'll see some benefit from that as well.
Thank you. Could I just raise, you mentioned housing and you mentioned homelessness. It is the case in Northumberland, particularly compared to cities, we don't, and one's too many, but we relatively don't have that many people sleeping on the streets as such. But we have so many people sofa surfing who are homeless, although not on the streets. Homeless. We have so many people living in overcrowded conditions, and all roads, anything that most things we talk lead to the housing crisis that we're in. And I just fear, and this is speaking generally, because of failures of successive governments, because there literally isn't enough houses, and because it's so difficult, you can, in some ways, find money for a problem, or pull out all the stops, but you can't magic more houses suddenly. And it seems to me we're part of it with what's happening with Home Finder, but the government are doing it always changing the goalposts. So they're changing what counts as overcrowded. So, you know, babies don't count as if you're an overcrowded house. Same-sex children don't count. If you're only one bedroom short, that's not seen as really overcrowding. So it seems that they're constantly changing the goalpost to kind of disguise the problem. So, you know, when I was looking at this, one of the things from a safeguarding point of view, one specific example that came up, if somebody's fleeing domestic abuse and they've been physically attacked, I feel that the agencies and the resources are there to help them and to find temporary accommodation anyway. But I'm aware of a lot of people that are in abusive, maybe emotional abusive relationships, but because of the housing, they're trapped in an abusive home because they think, well, it's awful being in this abusive relationship, but there's probably one thing even worse, and that's not having a roof over my head at all. So housing, I think, is, for all our work, is just so critical. And I know that there's not an easy solution because there just isn't enough houses because they haven't built enough and they haven't dealt with the crisis. So I don't know, and I know you're always looking for solutions and how we can help, and I think sometimes there's a danger to be part of this, just try to hide and disguise it and changing the goalposts about what's considered overcrowded and so on. And I think that we just need to be really, and it may be something of a specific piece of work that we can think about, but I think just housing is just so critical at the moment. If anyone hasn't got any questions, I'd just like to thank you, but could I just ask you both to finish and just give a bit of advice for signposting, so when we have in our work come across a safeguarding issue, if you could both from an adults and children's point of view just give a bit of advice, useful to everyone, particularly newish counsellors, about signposting, what do we do when we come across safeguarding issues.
So I've got two pieces of advice. One is, if it's urgent, ring the police immediately. Don't try ringing services. If it is so urgent, then call the police. And my second one is, have one call number logged into your telephone, because actually that's the next number that you should call, and one call will escalate that immediately.
And I was being a bit naughty there because ours is exactly the same. We share the same entry point to the organisation, so whether it's an adults or a children's issue, generally it's one call as your start point. So, I mean, there is sometimes a tendency for members to email Audrey or I directly on issues, but that won't be a quickest resolution necessarily. That's dependent on us picking the email up or something like that, which can't be guaranteed if we're not about or busy or whatever. So in terms of the two key areas, police and one call, I would have said. I absolutely agree with Audrey.
There isn't an email for one call, is there? Or is there? There is an email for one call, because it just
There's an email for the vulnerable adults if you think there's a safeguarding issue that you can fill in online.
Because sometimes you get the information from residents and you think it'd be helpful to just collate the information, but sometimes email, and if it's out of hours as well. So is it just one call at Northumberland? You recirculate it? That's great. Finally, does anyone have anything else on this report? Well, thank you very much, both of you, for that.
Sorry, I'll try and do everything.
Okay.
But we do have some training, elected members training planned, just introduction to safeguard training. I think it's in January that it's planned. We cannot remember the date, but just to plug that as well while we're here, and that will give a bit of a understanding, signs of abuse, and it also includes what to do if someone discloses or you become aware of abuse or safeguarding issues. Thank you.
Great, that'd be really helpful. Now, the next item is dentistry in Northumberland. Give an overview of the dentistry provision in Northumberland, and we have Pauline Fletcher of the ICB. So thank you for coming, and over to you, Pauline.
Thank you, Chair, and Happy New Year to everyone. I think it's a while since I was last here, and I understand that there are a number of new councillors, so I thought it would be helpful just to give a quick overview of NHS dentistry, and particularly the challenges, before I go on and tell you about some of the recent developments, both nationally and locally, and what we're doing in our efforts to improve oral health and access to care. So the ICB took on the responsibility from NHS England for dentistry services in April 2023, and there's been a lot going on since then. I think a key point to note is that primary care dental services are commissioned on a nationally mandated contract and have to be commissioned on units of dental activity. You've probably heard about UDAs, that's the acronym, but that's units of dental activity. Unlike GP services, there isn't any formal patient registration. That may seem a bit weird, because I'm sure if you are fortunate enough to have a dentist, that you probably, they will call you their registered patient, but under the contract, they are only contractually obliged to see you whilst you're in an open course of treatment. They do not have to provide under the contract ongoing routine care. A lot of dental practices do, but contractually, under that national framework, they don't have to do that. They manage their own appointment books. It's clearly down to the practices, the patients that they do offer that ongoing care to. We obviously have specialist community and hospital-based services, but I would suspect that a lot of what you're interested in is the general dental access. I mentioned about some challenges. Apologies, I know this slide's pretty small, that are available obviously in your packs. The challenges that we have, believe it or not, COVID-19 and the impact that had on dentistry is still an issue, because we still have a significant amount of patients with high dental needs and a much more increased demand than we had pre-COVID for urgent care. Like many other NHS services, workforce recruitment and retention is a significant issue, and particularly so within dentistry, because if you don't have the dentist, you can't provide, if you don't have the workforce, you can't provide the dental treatment. So it is a key limiting factor. Unfortunately, what we've seen, not just locally but nationally, is a shift towards more private dental care. So we've seen a number of dental providers that have either exited the NHS altogether or have transitioned their practices into private dental care. And I think it's fair to say that across the North East and North Cumbria, and particularly in rural areas, we have struggled to get interest to re-provide that capacity when it has been lost. We do have, because of those workforce issues, we do have practices that are not able to deliver the full level of contracted activity that we commission from them. So again, we've got money tied up in contracts that unfortunately some practices are struggling to deliver. I think particularly a concern is around the routine access, and I think all of those issues are really impacting on us being able to recover access back to where it was at pre-COVID times. On a more positive note, national reform is underway. I think there is a concern though, and I think it probably needs to be acknowledged, that the dental profession feel that it doesn't go far enough and more radical change is needed. But there are some more significant reforms that will help the situation in terms of particularly patients who need urgent dental care or those that have got more complex dental treatment. Urgent care is a national priority. Every integrated care board has been given a target to increase access to urgent care. It was already a local priority for us, so we have done a lot of work in that space, which I will share with you in a moment. Some of the other measures around the national reform, which is meant to be implemented from April of this year, I can say this year now that we're in 2026, is that every practice is going to be mandated to provide a certain level of their contract as urgent dental care. There will be increased payments for patients who have more complex treatment needs. So one of the criticisms previously was that patients with more complex treatment needs that have to attend dental practices on a number of occasions, that the current contract and the UDS system didn't remunerate them practices sufficiently for that work. So there's some reforms coming in that will provide some extra funding for those types of patients. There is increased use of skill mix, so they are making it easier for practices to skill mix, to use dental therapists within their scope of practice. There's also a national push around reducing unnecessary checkups. I think we've all heard that there's been a culture previously of patients going to the dentist for a checkup every 6 months. And actually, for adults dependent on your oral health needs, that is not necessarily clinically needed. So I think your recall interval in terms of going to a practice is based on an individual assessment of your oral health needs. There are some other quality measures around peer review, around sort of supporting appraisals, those quality measures to make sure that practices are delivering a quality service. The NHS 10-year plan, that sets out an ambition to transform the dental system by 2035, focusing on prevention, community care and integrated teams. We're not quite sure, obviously, what that's going to involve, but as I say, I think the dental profession would welcome something more radical that moves away from the current arrangements that are in place under the national contract. At the present time, there's no new national investment, but we are quite lucky within dentistry as the money that we get is ring-fenced for dentistry at the moment and can't be used for anything else. So I think that's a real bonus, which means that when we have contract handbacks and money is released, we're able to try then to re-procure additional capacity using that money. I think one of our biggest challenges, and that even with the reforms, is going to continue to be access to routine care, because a lot of the focus is on more complex patients and urgent care, and that will take up quite a lot of a practice's commissioned capacity. I will come on to tell you some of the things, because we have had some movement in terms of increasing capacity in Northumberland, which I'm hoping you will see as good news. This slide just really summarises what the current number of contracts that we've got in Northumberland and how many units of dental activity. Probably doesn't mean anything to anybody, but that equates to units of dental activity, equates to dental banding, and dependent on the type of treatment that practices get, practices are allocated a certain number of UDAs, so they have an annual target. So what are we doing to improve access to dental care? We have worked with our partners, the local authority, to develop an oral health and dentistry strategy, and the key vision for that is around reducing health inequalities, preventing dental disease and improving access to high quality dental care. Our priorities over the period of the strategy, which is a 2-year strategy, is to try and do everything we can to prevent, to increase preventative oral health interventions, to continue to make sure that we're improving access and we've got sufficient access to urgent dental care, to improve access to routine care, but also with a focus to improve workforce recruitment and retention, because that is a key limiting factor for us at the moment. In terms of improving oral health, the Integrated Care Board has invested £2 million to the local authorities and the combined authorities to tackle oral health needs. So some of the things that the money is being used for is around supervised toothbrushing and also for providing oral health kits for children, special needs families, older people in care homes. And of course you will be aware of the approval of the water fluoridation programme and the expansion of that. This slide just gives you a high-level illustration of how to access dental care. So, under the contract, High Street Dental Practices are commissioned to provide both routine and urgent dental care, but I'll just refer back to what I said before. It has to be commissioned on units of dental activity, and they determine how those units of dental activity are utilised. We do have a number of practices currently that are commissioned to deliver urgent appointment slots as part of a local incentivised access scheme. And we have recently put in place a network of urgent dental access centres to try and make it easier for people and to provide that capacity for urgent dental care. The guidance is only to contact 111 if you have what we call a clinically urgent dental need and can't access care through those other routes, i.e. the high street dentist. I'll come on to tell you what we mean by clinically urgent dental care. One of the things that gets mentioned at all of the scrutiny committees that I attend is people just don't know what's available and how to navigate it. We've done a lot of work in terms of improving the information available on our website. The link is in the presentation. If you go on our website, under the Here to Help You page, there's now a dedicated dental link, and that'll give information around how to access routine care, how to access urgent care, but it'll also tell you more around what we're doing in terms of the strategy and give some guidance in terms of, I suppose, self-help, how to look after your teeth. So, key priority has been urgent dental care. We have continued to increase the number of treatment sessions available out of hours because of that increased demand. We've also invested in the dental clinical assessment service that sits alongside 111. We've increased the workforce capacity so that they can respond in a more timely manner and deal with the demand. I mentioned the incentivised access scheme. We've commissioned this financial year across the whole of the North East and North Cumbria 100,000 additional appointments, but you'll be interested in what we've done for Northumberland. In Northumberland, this is purely voluntary from the practices. We have commissioned over 11,000 appointments, and we currently have 11 practices doing that scheme up until the end of this financial year, when the new arrangements will kick in, where every dental practice will be required to deliver a percentage of their contract for urgent dental care. One of the things that we think has been a bit of a sort of game changer is we have invested in a network of urgent dental access centres. You might hear them referred to as UDACs. We've got 3 sites in Northumberland, and they provide 210 urgent care appointments per week between them. So we've got one in Alnwick, which is the Genix practice. We've got the My Dentist practice at Cowpen Road in Blythe. We've got the Alpen Dental practice in Hexham. They are the 3 designated urgent dental access centres. We also still have some urgent care appointment slots up in Berwick, delivered from the provider up there. They are for clinically urgent patients and are only bookable through 111. What's different about these UDACs is that patients can actually book the appointments directly via an online booking portal. So if you go on our website and click on the Here to Help You, the dental tab, and you go to the urgent care, if you scroll down, it not only tells you the practices that are doing our incentivised access schemes and gives you the contact details, but it lists all of the urgent dental access centres, and there is a link there that will take you directly to their website for the portal. It's an NHS, it's the ICB website. So on this slide here, that is the link, the email. Yes, if you click on that, it'll take you directly to our site. Just go back to urgent dental access. So, these urgent dental access centres have a mix of appointments that are directly bookable, but there's also some protected appointments for patients who have got clinically urgent dental care needs and may come through 111. They are 30-minute appointments, and the rationale for that is to give the clinicians time to assess and diagnose your problem, and to also provide definitive treatment. And we've had a lot of positive feedback from patients who have used these centres. I mentioned about clinically urgent and when to phone 111. The blue box on this slide, that denotes the types of conditions where you need to be seen most quickly. So if you can't book an appointment through the UDAC or through your dental practice, then ringing 111, they will have access to appointments in the UDACs, in the out-of-hours services for patients with those types of conditions. But I mentioned that we've got a lot of patients that still have significant sort of dental needs. Now, they might not meet that clinically urgent threshold. So what we've done is we've broadened the scope of the urgent dental access centres to include less clinically urgent treatments. So non-urgent treatments, for example, bleeding gums, mild to moderate pain, minor trauma, loose or displaced fillings without pain. Previously, if you ring 111, they will just direct you back to your practice, but you will be able to book appointments yourself through the urgent dental access centre links for those. Just to be absolutely clear, these centres are not walk-in and they're not for routine care such as checkups. As I say, the links are all on our website, and I think we've seen, since we introduced these, I think we've seen a significant drop in the number of enquiries and complaints we get for patients who require urgent care. So it seems to be addressing that need. Improving access to routine care, I think that's a bit more challenging to address, but some of the things that we've done is we've increased the minimum rates that we pay to our dental practices. We've also offered practices the opportunity to be paid to deliver more activity than they're contracted to deliver. So any practice that's in a position to deliver more treatment, we've given them the opportunity to do that and to be paid for that. We also, we try wherever possible to try and prevent contract handbacks. Sometimes we don't always know until the provider comes to us, but if a provider comes to us to say that they're struggling, we try to support them within the regulatory framework and do what we can to try and keep them within the NHS. Unfortunately, that doesn't always work, and you'll be aware of the recent practice that has moved to private, or will be moving to private at the end of January, which is the Cramlington dental practice. When we get a contract handback, we try to recommission their activity as quickly as possible. Now, within Northumberland, we've tried formal procurements. We had some formal procurements in, I think it was early 2024. Unfortunately, from that, we were only able to award one contract, and I think it's fair to say there's been some challenges in getting that contract up and running and started. We are working with the provider. There's been some challenges linked to premises outside of their control, and we are hopeful that we're nearing the end of that and that it will open shortly. The aim is to try and have it open by the end of this month, if we possibly can, but there are some external issues that will need to be addressed. So that will give additional capacity in Berwick. Because of the sort of the limited market interest, what we have done is we've been out to every practice across Northumberland to see if they are able to deliver on an ongoing basis additional activity, and I'm pleased to say that we've had some success with that. So from April, we have commissioned an additional nearly 33,000 UDAs from 7 practices across Northumberland. There is some additional capacity, nearly 10,000 UDAs that will be delivered this year. To make sure we're not tying money up in contracts that then can't get delivered, that activity has been commissioned on a non-recurrent basis. However, there is the promise that if the practices deliver their activity and are able to deliver their activity reliably, then it will become permanent. We will be going out and looking for expressions of interest to try and replace the capacity linked to the Cramlington dental practice, if we possibly can, because I think that we became aware of that after that exercise had concluded. Finally, in terms of workforce initiatives, we work very closely with what used to be known as the Deanery, but is now the NHS England Workforce Training and Education Department, on initiatives that's going to help sort of stabilise the workforce, upskill and actually grow the dental workforce. So we've invested 1.1 million on a number of schemes that they are taking forward to try and retain skilled workforce and to try and make sure that it's attractive and they've got the training opportunities and they're able to undertake the types of work that they want to undertake. There's some examples on the slide of some of the initiatives that the Deanery are doing with that funding. And then lastly, and this is probably unique because I think we're the only integrated care board in the country that has done this. We've actually paid a loyalty bonus to our more experienced dentists. It's very difficult once a dentist and once a practice makes a decision to go private, it's very difficult to get them back. So what we're trying to do is retain the experienced dentists who can provide the broader range of treatments in the NHS as quick, as long as we can, and hopefully working with the contract reform and some of the changes, we might get to a situation where, the NHS contract is seen as more attractive for them to stay. I think that's it, and I'm happy to answer any questions.
Thank you. Just say thank you very much. Can I say, first of all, the slides will be made available? Yes. And just with the slides, is there any additional data that you could send us? It would be useful to have, and I get the point about it might not be necessary the 6 month, this whole thing, but would it be, it'd be really useful to get some data like how many residents in Northumberland have seen a dentist in the last 6 months? How does that compare to the rest of the country? How does that compare to 3 years ago? That sort of data would be quite useful. Would you be able to, and it'd be quite good to look, if we could, different parts of Northumberland as well, because those are the sort of data that you can sort of identify trends. So if you could pull something up with this, send to Rebecca, which you can send out to members, that'd be really helpful.
So on our website, one of the tabs is the oral health strategy, and in there's a lot of information about the oral health needs of the population and some of those additional stats. We're also doing a lot of work with our IT people on dental dashboards to be able to provide that information. In terms of number of unique patients seen, we will be able to provide that. I don't recall whether that's actually in the strategy, but if there's anything that's not in the strategy that you feel would be useful, then more than happy to source that if it is available and provide it to the committee.
Thank you. Sorry, I didn't see quite the order, but I'll go with you first and then Councillor Davidson.
Thank you, and thank you for that presentation. It's really good to see that there is a lot of work going on in the background to address a growing problem. I think we've seen this problem grow year on year for 30 years, if not more. But I think if you ask most people, the number one issue that seems to not be tackled government after government, decade after decade, is the fact that we just don't have enough NHS dentists for people to get to. Particularly an issue for rural areas that have to travel. Travel is one of the biggest barriers that we have to efficient healthcare. Prevention is always better than cure. But when you say to somebody who lives rurally or even semi-rurally that they have to travel into the local town to find a dentist or whatever provision they need, if they don't have the luxury of being able to have a car or medically are not able to drive, the transport system isn't there. It is not there. If you live in the villages of Seaton Valley and you're told your nearest dentist is Morpeth or Killingworth, Whitley Bay, most villages can't actually get there. There is no public transport to them. We used to have dentists in most villages, so sort of nearby that did NHS work. That just is not there. We're all aware that the NHS heavily subsidises the training for NHS dentists, but then there is no barriers to those NHS dentists then just moving off. And as soon as they, as you rightly said, as soon as they get a taste of what private dentistry is like and the kind of money that you can make from that, you are not getting them back. Absolutely not. We do not have enough NHS dentists to go around. Again, government after government has ignored this problem of dentists just moving off and going into the private sector. What I would really like to know is, you're on the front line of this, you're dealing with this, you're seeing the figures, you're seeing the facts, probably year after year, you know more than anybody in this room. How much influence do you and your teams actually have over the larger bosses at the NHS and then passing that information on to subsequent governments to say, this problem needs to be addressed now and we need to stop the mass exodus that is just allowed to happen? The taxpayer is heavily subsidising the training but then gets nothing out of it. So how much influence do you have, and are they actually listening to you? Thank you.
So there's a lot in that. First of all, in terms of training of new dentists, the responsibility for that lies with sort of NHS England, and I'm aware that there was a national consultation around a tie-in of dentists after they've been trained. It's gone a bit quiet on that front, and I must admit I don't know where that has landed, or whether that's still even on the cards. What I can say is, as an ICB, we have done a lot of work both responding to the consultation around dental reform. We've also engaged with our local MPs. We've recently had sessions with them to make sure they understand some of the issues and the challenges so that they can influence the direction of travel. So we do use every avenue we possibly can to try and get the challenges and the local messages across. I think we're starting to see some of that happening, but I think there's probably a lot more that needs to be done, particularly around routine dental care. I think urgent dental care seems to, with the focus and the push both nationally and locally, seems to be addressing the need. But I think absolutely I understand the challenge around the limited amount of dental capacity, and also what that impact is for routine care. It would be great if there was a bottomless pit of money that we could then get dental practices across the patch. Unfortunately, that is not the case, but we've also got challenges in terms of the workforce and the providers. It's got to be financially viable for them to come into an area. So what you tend to find is a provider would want a contract of a reasonable size to be able to make that financially work for them. So I think we're in a sort of, it's a constant challenge to try and get the capacity, particularly in rural areas, but then try and get the capacity into some of the more remote areas of that rural. I wish I had the answer to that. I think it will continue to be a challenge, but we are trying to do everything we can to increase the access that's available.
Right, I'll take in order that I saw Councillor Davidson, Councillor Jones, Councillor Austin, and then Derry. Can I just take them, do you mind taking them all at once and just answer? So Councillor Davidson first.
Obviously as big as everybody else's, but we have one dentist who aren't taking in any more private patients. There are roughly 1,000 houses being built in a very small area of one of my wards. So we reckon that's going to be about 3,000 people. How is the system, even with the, the urgent dental access, how is this going to be able to cope with such huge numbers of people?
If I could bring Councillor Jones in, and then
Thank you. You did actually refer to it in your answer to a previous question, but I just want to say anyways, there's some very good stuff here, but it's all based on urgent care, and there's very, very little about preventative care. And it just seems, I take the point, and I think we all do, that you don't need a checkup every 6 months. But to go from you don't need a checkup every 6 months to we don't do it at all seems a big step, because that's what's happening out there, that people don't have the ability to go and have a checkup. And for people, older people particularly, poor oral health, as you know, and it just seems that if somebody doesn't spot an area that needs a fill-in, that's going to become urgent, and a lost tooth, etc. So I just think, I know you're doing your best, but we do need more on preventative health.
And I just mentioned in there as well, of course, seeing a dentist can be an early spotter of some oral cancers and other things as well. Councillor Austin, and then Derry, and then I'll bring...
Thank you very much. It's a very simple question. Does a visit or a consultation with the dental hygienist count as a UDA? And if not, can we make it so?
Okay. And finally, before we go back, Derry, I'm sure you're probably going to mention, we'd be interested to know if Health Watch have seen a decline in complaints, so probably what you're partly going to say anyway.
Yes, as you can imagine, I was really pleased to see this presentation was here today. As members will know, this has been a major piece of work for not just Health Watch Northumberland, but the Health Watch network in the North East and Cumbria, but nationally. I think for the very positive things that you were able to report on, Pauline, I think that is to be welcomed. I think some of the stuff around the incentivised access particularly was really interesting. I think the figures of what's been available is good, but I think where we're interested in what's the take-up been like, because I think that's the test of it, because I think one of the big issues that we identified all the way through this was that people's knowledge and information about what is available is one of the biggest barriers. And I think, to answer Georgina's question, is that we have seen a lessening of feedback, but I don't think that is because people are necessarily getting everything they want. I think some people have given up. And I think the message that, because we still do get people saying, and I think if anyone is on their local Facebook groups, you still see people all the time saying, does anyone know if X or Y is taking NHS patients? So I think there is still a big need for better information, and we were really pleased to see the improvements in the NHS website, because that's one of the big recommendations from Health Watch nationally as well as locally, and I think we would definitely score that as a result. But I think this issue around incentivised access is only good if people know about it and take it up. So they can be there, but are people. So I'd like to see those figures reported. There's just one further thing. Is one of the things that was in the recovery plan, dental access recovery plan, that was muted but then seemed to disappear, which was mobile services. And I remember getting really excited because there was this talk about there were going to be 9 services and they were going to target rural areas, and then they seem to have gone away. So I don't know whether they were ever enacted or they were enacted in other places than Northumberland. But again, given everything that members have been saying today, I think that's a really interesting thing that we can all continue to push on. And I would say to members as well that if you are still getting people who are raising issues around that, then do let us know, because as a local, regional and national network, we would still see it as one of the priorities that we need to push decision makers on. Thank you.
Thank you. A few things to pick up there. Thank you. Yes.
Okay, I'll do my best. Apologies if I haven't sort of quite got the nuances of the questions. I think the first question was around, you know, where you've got areas where there's increased housing and increased population, how we're going to meet that demand. I think that is going to be challenging, because I would say over 90% of the dental ring-fence budget that we've got is already tied up in contracts. So I think it is about repurposing some of that money to try and address the gaps in provision. But I think the challenge is the market availability. So there's potentially a funding issue around, we need to have the money freed up to be able to increase the amount of capacity that we're commissioning. But there's then also the challenge, as we've seen when we've done procurements, around the market response and how we can make it attractive to attract people in. As I say, we've had some success around existing practices. We're trying to max out the amount of capacity they're able to deliver. But if we do need to procure some additional services, then obviously we'll try and do that within the financial envelope that we have as an ICB for dentistry. Sorry.
Oh, sorry. For Alnwick and Blythe and Hexham, you mentioned 210 appointments. Is that for all of them, or is that for each one? It's combined. Right. Right. Thank you.
Obviously the concern. Oh, yeah. Sorry, I thought I'd switched back on. The concern around, you know, access to routine checkups. I think it is a challenge, and I think it's one that's we're not going to be able to fix overnight. What we are trying to do is work with our local authority colleagues in terms of other preventative measures, because the best thing to do is to try and get to kids early where you can then prevent the dental decay. So I think one of the biggest game changers has been the water fluoridation extension. I know that's a longer term initiative, but some of the stuff that is happening around toothbrushing in schools, etc. So I think it's, you know, we're not putting all of our eggs in one basket. I think there's lots to try and prevent the disease happening in the first place, to reduce the reliance on patients having to come for dental treatment, but absolutely get the importance of checkups at an interval that is appropriate. And that's why we're trying to grow the capacity as much as we can, notwithstanding those challenges that I've outlined. In terms of the dental hygienists, and does that count, if you see a dental hygienist, does that count as UDAs? So as part of the reforms and as part of the skill mix, there are some changes coming that will allow more of that to happen in terms of treatment by the therapists, by the hygienists, as part of a sort of an overall course of treatment. So it is factored in within a course of treatment, and there are UDAs associated with it, but currently it needs to go through the dentists initially in terms of that. But there are some changes that are happening to encourage that even more. Dental therapists can see some direct access patients within their scope of practice, and that is funded through the NHS as well. I think the next question was around around the take-up of the incentivised access scheme. I don't have the figures with me, but I can certainly provide that to you, Derry. That scheme, though, will come to an end at the end of March. We're being mandated that that has to happen because the new arrangements whereby every practice will have to do a certain amount of their activity with urgent care is coming in. But I can certainly give you some of the figures.
And will, under the new contract, will that be measured as part of contract management? Would that be a performance indicator for the new contract? Be a take-up of that?
So my understanding currently is that a proportion of their contract will be top sliced and have to be delivered as urgent courses of treatment, and that in the same way as practices, when they see a patient, submit what's called a claim form, a FP17 form, into the BSA, then that would get captured in that way. So they'll have a target in terms of what they have to deliver, and that is not remunerated on UDAs. It's on patients seen. I think you comment about the information. Yes, there's probably more we can do to make that available. Hopefully you'll see that what we have done, because I know Paul Jones from Healthwatch has been representing the Healthwatch colleagues to help us in terms of improving. But if there is any further thing that you think we can do to, sort of improve that information, then absolutely feed that back. We want to make sure that the information we're providing is as informative as we possibly can, and to try and make it easier for patients to access the services that are available, notwithstanding what I've said about the routine access and the challenges for improving that. Mobile dental services. Okay, so there was, under the previous government, there was an initiative to roll out mobile dental services in areas that they selected as being the most in need of that type of service. None of our local authorities was identified for that. It is something that we have previously explored. Unfortunately, it's a very expensive way to deliver services. I think there are some challenges about the amount of, I suppose, the benefits that you get for the level of investment that you are providing, because it's very difficult to provide the full range of treatments like you could in a fixed dental surgery. So we took the decision as an ICB that we wouldn't explore that any further, and that we would progress with the urgent dental access centres to try and make that a sort of a more reliable, a more cost-effective, but more sort of available in terms of access for patients with urgent dental care.
Jill, and then Councillor Oakley.
Thank you. Not a question, just more to come in on the back of the prevention conversation, and to provide some assurance to scrutiny that as a public health team and as a local authority, we are responsible for oral health promotion to sit alongside and support our NHS colleagues. So when the funding did come through in relation to the supervised toothbrushing schemes, the back end of last year, we've been working through the commission. So we are going to be working with Northumbria Healthcare Trust. You will start to see that rolled out this year, particularly targeting nurseries and also working with health visitors in our most deprived areas in the first instance, but then rolling out beyond that. That is absolutely the right thing to do from a primary prevention perspective, and just linking that to the fact that actually with healthy teeth we do not need those 6-month checkups, and actually the evidence base is that we can go up to 2 years with healthy teeth. But the point that Councillor Jones is making is that gap between high need treatment and primary prevention is early intervention piece, which is why we do need that continued pressure and push to try and expand the NHS system, to have a change in cultural expectation from society that within a 2-year cycle people can expect to have that routine dental appointment. But that is going to take a real cultural shift. We've all grown up with that expectation of having a 6-month checkup, and actually the evidence doesn't support that for healthy teeth. And just coming on to the community water fluoridation, that is obviously it's been through scrutiny here. It was a national consultation led by NHS England. That will still take 5, 6, 7 years to come to fruition for it to start to see impact in our oral health, but it will show that within the population level. We know for the areas that we want to expand it into for Northumberland. So just to provide some additional local context in relation to the public health support team.
Thank you for that. Councillor Oakley?
Hi, I'm trying to pull some bits of information together that you've said. So you said that next year there would be 33,000 new urgent dental appointments across Northumberland. You also said... No, that's okay. You also said there'd be a percentage, each dental practice now has to do a percentage of appointments that are NHS appointments. Is that 33,000 over and above the percentage, or is it included in that? And also, what percentage of dental appointments do have to be NHS ones?
So the, sorry, oh dear, remnants of the flu. So the 30,000 that I referred to, they were additional UDAs, so can be used for routine care, can be used for urgent care. That is different from what I was talking about in terms of the reform, where they'll top slice the contract to provide appointments for urgent care. So this will be an increase to the overall capacity.
What percentage is that top?
I am really
Happy to share your email address, and if people have got any further, because you're obviously we probably need to press on. So I think in conclusion, I think Derry's backed up what I said in terms of correspondence with residents. There does seem to be, at one point it seemed really critical and really awful situations of people literally teeth falling out and awful, and couldn't, so there does seem to be focus and improvement on the urgent care side, definitely, and it is clearly a focus on this. We are obviously concerned about the long-term impact of, there's lots of people that are, just as you said, Derry, given up. We've just thought, and they might be okay at the moment, but you can build up problems, cancer detection and so on. So that's something that needs to be monitored, the long-term impact, and also feed in anything we can do. I think as cancer's just leaving. What's her name again? It's the cold, Eve Chicken, yeah. The things about the incentives for training dentists, it's not just bonuses for retention, but it's about incentivising people who train, pay for them to get trained, incentivise them, but tie them into working for the NHS for a certain amount of time. So that was really helpful. Thank you very much. Now, it is 2:33. We'll start back at 2:30 because I think people need a comfort break and actually to start moving, because I can tell everyone's getting a bit cold. So at 2:40, we will start back. You've got 5 minutes. take your seats. Right, okay. Veronica, would you like to introduce this item? Yes, I thought, because you worked on it.
It's going to be very brief. Just basically, I mean, you know, a lot of work has gone into the Energising Blythe project. Part of that, though, is the community and the coming together of the community, which affects everybody's health and well-being. And Heart of Blythe, through public health, has been part of that and has brought together all the community groups, community organisations, town council, I think, as well, yes, and all the people in Blythe who basically, people in Blythe who care about Blythe, and it's brought together a lot of things, been lots of events and lots of people coming together. I was just having a laugh with Liz, so I will say it's about watching two of our county councillors at an event doing a session on learning Tai Chi in public, and it was really well worth watching. Your turn next, Eve.
Okay, so we've got a bit of a double act today. You'll have had the slides have gone out in your packs, so, and we're conscious of time, so we're literally going to really whiz through them. My colleague, so I'm Liz Robinson, Senior Public Health Manager in the Public Health team here, and I was involved from the start of the Heart of Blythe project, so I have a bit of the historical knowledge, but also Karen McCabe, who's in a snowy village in North Northumberland, quite away from the A1, so joining us online today. Is sort of following on a lot of the Heart of Blythe work and sort of how we embed the learning in the future. So you'll see in your slides there were a series of questions that we were asked to cover, and we've provided a little bit more information on the sort of the local context. So that's on your first slide, but I'll hand over to Karen to just talk a little bit about the background to the project and how it came about. Over to you, Karen.
Thank you. Hopefully you can hear me. Liz, can you answer so I know? Yes. And I'll keep going. The slides don't seem to want to move on, so apologies. I'll keep going and see. Oh, there we go. So we were asked to come along today and share an update on the Heart of Blythe programme and to cover some of those key questions, as Liz has mentioned. Just wanted to start with a little bit of the context and not to spend too much time on this. The Heart of Blythe project was part of the UK-wide Shaping Places for Healthier Lives programme. This was funded by the Health Foundation and Local Government Association. One of the priorities for the Health Foundation is to increase health and well-being, reduce inequalities by understanding the role that economic and social factors play and taking action on these root causes. The application to be part of this programme was a competitive process. Over 100 public health teams applied from across the UK, and 5 areas, including ourselves, were successful in being able to take that forward. Excuse me. And the programme ran, it was a time-limited programme that ran from October 2021 to October 2024. As you'll see from the slide there, the key aims were to address health inequalities, focusing on those building blocks of a good life, build from and on local partnerships, and embed sustainable actions. The programme is data-led and evidence-based. We know that strengths and asset-based approaches and place-based approaches are evidence-based. There is a raft of evidence around the value of local community-driven action, around social capital and around building resilience. This was the way and still is the way that ourselves as the public health team and wider teams across the council are already working. And we know from the data that Blythe is one of our areas that experiences inequalities. Liz has mentioned the Energise in Blythe programme. This programme complemented the work that was being taken forward by Energise in Blythe and was able to robustly enhance the community-led approaches within this. There was also local support and appetite and enthusiasm to get involved, and as has already been mentioned, when the application was submitted, there were letters of support from the police, from housing, the town council and voluntary and community sector partners. The first part, as I mentioned, it's a 3-year programme. The first part, the first 6 months was about discovery. So whilst the programme was loyal to those wider aims of reducing inequalities by building partnerships and sustainable action, the local focus was very much co-developed and locally driven. It was really important that we understood what mattered to local people and to people here. So during this 6 months, a number of engagement activities took place across Blythe. All Blythe wards were involved, and there was some specific targeting to ensure that we were able to engage those often quiet voices, those who are often underrepresented, and young people as well, again, often underrepresented in programmes. This came at a time that we were emerging from the pandemic, so there was some creative ways taken forward in engagement, and you'll see from the slide there that over almost 300 people took part in different varieties of surveys, almost 60 people took part in group sessions, and 18 classes were involved as well. What we learned from this, we learned that people are proud and passionate, that there was a real energy and positivity in taking this forward, that the existing assets in the local community were really valued, and that people and relationships were key to taking this forward. And I'm going to hand over to Liz in the room now to talk you through some more slides.
Thanks, Karen. So as part of the application process, we had to develop a theory of change, which is something that was quite new to us, is where you think of all of the assets that you've already got, the activities that you're going to take place and how they all fit together to achieve your overall aims. So that's what we did. We did that in not in a dark room, but with those workshop sessions with a lot of the organisations that we've been working throughout this discovery phase with. It boiled down to sort of 3 key areas that we wanted to focus was to build relationships, connections between different community groups, groups that might not normally come together, perhaps because they're at different age bands or intergenerational or different socio-economic groups. Also to get people more involved in looking after the area and improving the way how Blythe is seen and how it looks. So in the sort of purple shapes underneath, you can see the type of actions that sort of led us to focus on. So opportunities to bring people together was one of them, providing some sort of coordination and networking, trying to connect people into what's happening in the town. There's already a lot of work goes on in Blythe. I've learned a lot about Blythe, not being a local resident, of how much there is happening, how many volunteers there are doing lots of really good work and lots of community groups, and how the Blythe Town Council, does a lot to make sure people are aware of all the activities in the area. And also we were really keen to try test some approaches to involve residents in some decision making. So that's where the microgrant process came from. So yeah, that was the main focus of what we did over the 3-year period. Next slide, please, Karen. So just click through this. I think there was an interest from members about understanding some of the oversight of the Heart of Blythe project. So I've tried to think about this in different ways. So we did have oversight from the Health Foundation and the Local Government Association as funders, monthly meetings, monitoring meetings and quarterly reports. The Health Foundation were also really keen to capture learning from all of the 5 sites. So there was external evaluators who actually came and spent time with us
probably about 4 or 5 times, including developing workshops with residents who came along to understand what they felt about the project, and then a final project survey of all those involved in the microgrants. We had a local steering group that we set up even from the very first moment we thought about should we apply for this, that this involved Blythe Valley CVA, and as we developed the steering group further, involved other people in that group from other organisations and also different departments in the council. Ultimately, the public health team were responsible as part of the council and the accountable body to make sure the finance was spent correctly and reported on, and that there was due diligence carried out. So, well, there was project management support provided in kind by the public health team and financial management as well. In terms of that broadening out that involvement, we established a residents panel. So from the very start, when we started communicating and engaging with residents, they were invited, would they like to be more involved? So some expressed an interest in just being kept up to date. Some were more keen on being actively involved in the residents panel. So we established that, and by working with CVA Blythe Valley, we were able to put some training on for residents about how to give out grants. But we wanted some flexibility around that. So as well as making sure there was due diligence, they also were able to shape that process, and which I think was really valid. And I think a lot of people who received microgrants really valued that residents had made those decisions, and even when they were unsuccessful, kind of understood that process and seemed to be reasonably comfortable with that. And then finally, that keeping people sort of wider, more involved. There was email networks. We had quite a few events. We had 2 big celebration events where organisations come together and tell residents what they did in the area. So, yeah, different ways that people were able to be involved in that. Move on, Karen. So just focusing in on the microgrant element, this is where the residents panel designed this process. So over the period of the time they distributed 115 microgrants. They gave a lot of their time free of charge. We offered expenses, but they gave their time free of charge, and we kept a close eye on sort of monitoring who was participating in receiving the microgrants, who were the beneficiaries. We didn't want it to be just lots of older people, but we wanted to have a good spread across like younger people and older people as well. So we kept monitoring on that. And I don't think there's anything massively mind-blowing about what the microgrants funded. There'll be things that are probably similar things funded through other grant programs. But I think what was interesting is that there was some community development support alongside this. So it was almost like going to people who don't normally come forward to put in grants. And some of the learning was that once they got a little bit of confidence with this process and hand-holding, they then went on to apply for other grants from other funders. So that was something that was really useful. Often it's the quieter voices who don't get involved in things like this. And that was me covered. Next slide then, Karen, please. Yeah, so these are clicking up quick. I can't keep up with them. But some of the activities were funded. Some groups who through the railway marine medical practice, there was some sort of patient-led groups who wanted to set up and start supporting each other around their health conditions, and we were able to support that and bring in CVA Blythe Valley to help groups get constituted, and they're now continuing on and flourishing. There was a new residents group formed that we sort of came across at the very early stages of the consultation process, and we worked with them along with CVA to help them get constituted, and they've really developed a community house, and they've got little bits of land that they're looking after and things like that. And then other groups came forward and said, well, there's a bit of land I'd really like to look after. Can we develop a community garden using volunteers? The kids at the school were really keen in tracing the history of the mine in the area
and developing that as an exhibition, and that was available for visitors to see. So these are just some of the ideas that residents groups came forward and said that they'd like support with. So a lot around physical activity, supporting people to be more active, and just really come together alongside other people with similar interests. So there's just a bit of a snapshot. So you can shoot onto the next slide, Karen, when we get to the end of that. Yeah, these are some of the pain groups that were established. So as part of the microgrant process, we asked people to fill in surveys, and these are some of the things, I'll not go through them, but we asked people to say what were they most proud of. We also asked them what would they do differently and what did they learn. But you know, we've just picked up some of the examples that I think they really benefit. They found there was real benefit in that building community connectedness and feeling that they were valued because they actually had a voice. They developed an idea, they applied for funding, and they sort of implemented it, which made them feel sort of really proud as well. And that's it, Karen. Back to you, I think, now.
So I'll just come in to close the presentation there. And I know that this has been a very quick whistle-stop tour, but as I say, with the agenda, you should have had the learning report from Heart of Blythe. So all of the information that Liz has talked about there and some of the background I mentioned at the beginning is all in that report, if you'd like to have a deeper dive in there. So it was really just for me to close the presentation and say that whilst the Heart of Blythe project was a 3-year project that was time limited, the legacy and the learning didn't end at the end of the project. That has stayed alive. We do still work as an organisation and much more widely as a system across Northumberland in an assets and strength-based way and in a place-based approach to addressing inequalities. The learning from the Heart of Blythe has been shared nationally by the Health Foundation, and locally that learning has informed and shaped the development of, at a Blythe-based level, the Energising Blythe and Blythe Celebrates. And for us as an organisation, that learning and legacy has helped us in shaping our community's first approach. The coordinator role that sat alongside driving this programme forward has been integrated into part of our Connected Communities team that sits with myself in the Safe and Resilient Communities team, and that is a team across the whole council who are supporting our communities, building on the assets that are in our communities and supporting them to take forward interventions and initiatives that they are really passionate about. And I've just got one very small last slide at the end, which just pops up there because we weren't sure about the knowledge in the room about our community's first approach. And that is really about being able to enable residents to live independent, fulfilled lives, not reverting directly to service delivery, but really seeking to understand what assets are available in our communities and how we can support those assets, build those assets, and work with our communities to take forward this community and place-driven approach to addressing inequalities and improving health and well-being. I'll stop now, Liz, and hand back to you in the room.
Thank you very much, Liz and Karen. That was a very interesting presentation. I saw Councillor Green.
Thank you, Chair. Thank you both of you for that presentation. It was really interesting reading. 2 questions, possibly unrelated. The first one, you had some opinions and feedback very positive by the looks of it, except for one, which I'm going to press upon. It was a question in the report that mentioned, do people think that Blythe feels safer? And predominantly the answer was no on that. Do we know why is that and what are we doing about it? And also, we've learnt a lot there. We've had like 3 years of the Heart of Blythe. Can we take some quick initiatives? Tackle some inequalities without doing the 3-year study that you've already done?
I think for the bit about does Blythe feel safer, I think it's probably a wider set of actors and partners that need to be involved in that through the community safety partnership. It's not an area I'm massively linked into. I don't know if Jill has anything to say more about that.
If you would like to. I can do, yeah. I'll just speak, and then I know Karen wants to come in. So absolutely, it's an important question that was asked during that process of Heart of Blythe, but it wasn't necessarily a core ambition or outcome of the Heart of Blythe, but it is that sense of belonging, and that sense of place is really important. So as Liz has highlighted, the partnership is safe in their own communities, and we're doing a huge amount through the victim and offender liaison groups and looking at the antisocial behaviour work that's there, and we have seen a reduction in crime taking place in the Blythe area as well. So I think it was important to ask of that project, but it wasn't a specific expectation that that project will achieve that outcome. And I think just to follow on, and I'm sure Karen will come in relation to the how do we take the learning, this is exactly what we're hoping to achieve. It's not any more about a 3-year project. We have proven that this kind of working works. And if you look at how we normally think about improving the health and well-being of our population, and we talk about the building blocks, which is education, it's transport, it's employment, it's housing, actually one of the core things that we often forget is social connectivity. And what this project proved was how important that social connection is within a community, and that's exactly what Karen and her team are doing more and more with the voluntary sector across all different towns and villages across the county. But Karen might want to expand. Karen?
Just very small expansion to say exactly that we, the community connect, formally our locality coordinators and our senior health trainers and our Heart of Blythe coordinator, we've looked at a lot of the learning from the assets and strengths and place-based work that those staff have been taking forward and brought them together in a new team moving forward, so that we're able to really embed that asset and place-based approach, really linking within our voluntary and community sector partners, so that it doesn't necessarily, as we were saying, it doesn't need to be a heart of somewhere. It is just about how we operate and how we work in Northumberland to support our communities to achieve what they want to take forward around their health and well-being.
Rob?
Yeah, thanks, Chair. I'm Rob Strettle, Regeneration Manager at the Council, so it was just to answer the Councillor's question, perhaps on the other side of the coin, in terms of the people-based services that Jill and others have highlighted. There's also the infrastructure in these towns in terms of regenerating them and making them nicer places to live and to feel more safe. So in Blythe, when we started energising Blythe in 2020, we were trying to make it more welcoming, more safe and more accessible. I think we've made a really good dint in getting that on the right track with the interventions that have been made. We're well on the way to investing over £95 million in the town centre and other parts of the town. You've got a new marketplace with a new offer, adding value to the offer that's already there. Businesses and the community told us they didn't feel safe in the marketplace. The police have done an awful lot of work through Operation Aurora as well to try and tackle some of the issues with substance misuse in the town centre. So it's all of these things happening all at the same time to try and make improvements. And then in Ashington and Newbiggin, there are regeneration programmes in those two places. The Regenerate in Ashington programme is underway there, and the Borderlands Place programme in Newbiggin, which will both deliver improved public realm and increase in things to do in those town centres to add to that feeling of safety, both in the daytime and the nighttime economy. So I hope that's helpful.
Can I ask, I mean, Blythe's not far away from my area, well, relatively, so it's not a project I know an awful lot about. I know some of these things aren't directly measurable, and I know our remit isn't specifically, although it's value for money, but I mean, it's difficult to come to conclusions. So is data going to be captured? So, you know, I'll give it a kind of example. Are you going to say in 3 years' time we've noticed fewer people smoking in Blythe, or there's fewer deaths from suicide, fewer deaths in different indicators. I mean, how can we really, is there anything now and over the next few years that's really going to capture and a really non-negotiable, not a sort of, you know, these surveys, and people are a bit cynical about, do you trust the council more? But that, you know, that's people in Northumberland. That was just about half said, all right, trust them a little bit more. But how are we really going to measure it to really convince? And how much did it cost altogether?
So in relation to measurement, you're absolutely right. This is about a sense of belonging, a sense of feeling, isn't it? And therefore, any survey that we undertake is quite context specific. So what we've taken on board from the learning from Heart of Blythe is how do we look at that voice of community and to be able to recognise it alongside the quantitative data that you refer to, which is absolutely right and proper, as you say. We can measure hard stats like smoking rates or premature mortality. This is about complementary, so it's not comparing, it's adding to. I think it's really important from a qualitative perspective of social capital that's been referred to, and that social change alongside economic regeneration change. So the tool that we've been using over the last couple of years is the place standard tool, and that I know is now part of a core work in regeneration to be able to capture that. How do people feel now? And the intention is that if we go back in 3-5 years time, yes, it might be a different cohort we ask, but if we've changed that infrastructure and we've changed that environment, then we're able to ask the same question, but in years to come.
Does anyone here represent Blythe? You can ask. So I'll ask you this then. So I walked into a pub in Blythe and said, what do you think of Heart of Blythe? What would they all say? If anyone can afford to go to pubs anymore.
Yeah, it largely depends on what time of day you've gone in and how much they've had to drink. I think for the majority of people who are engaged in this sort of thing, who would take it upon themselves to read the magazines that come through, that advertise these things, that are connected to Facebook, who make a point of knowing what's going on in their area, either to use it themselves, to refer it on to other people, or to be part of it. They do know about it, and I think one of the greatest things that we can take away from this is that even though the programme actually ended more than a year ago, quite a few of these programmes that were started independently are still going. They've got a life of their own now. They're not being financed and funded and directed by the council. They've taken on their own life and they're surviving. That means that the community took that on board, they liked it, they saw it was worthwhile, and they've taken it off. They've gone with it, they're running with it. Some of them have slightly changed because that's what time does. It bends itself better to what the needs are of the people at that particular time, the needs of the people that can influence it, what they can bring to it. They might find something completely new that people go, that is it, we want a bit of that. To see that social change and to see that it is surviving on its own without that overarching influence is a success in itself. Only time will tell when we look much further down the line at data to see exactly how specific we can really be, because there are all sorts of other elements that come into that. But the fact that the community does know what it is, they are connected with it, they talk about it, it took a life of its own, and that has continued thereafter. The support mechanism, quite often these things actually just fall apart once that overarching support mechanism has gone, that structure, that continuance of people working on it has gone, it sometimes falls apart. A lot of these programmes haven't, and the fact that they're still there, I think, is testament to it, and testament to those that put the work in to get it up off the ground to begin with. The fact that the residents, a lot of them, and obviously community leaders have taken them up, I think, is the most positive thing to take from it.
How much was it altogether? I saw 160,000 for grants. What was the total?
So the total was 300,000. Right. 300,000. 195,000 was for the micro grant. So the remaining budget was to support the coordination role. We kind of tapered that off. So by the end of the years, public health was contributing more and more, and the Heart of Blythe grant was contributing less and less, so that it was mainstreamed. And then we supported like community events, celebration events. That's where so we tried to put as much into the micro grants as we like possibly could.
Great.
Thank you. I think it's really, really interesting, isn't it? Because, you know, social return on investment is one of the most difficult things to measure. But I think as an agency that works across Northumberland and is trying to always hear those quiet voices, I think Heart of Blythe has been a really interesting, and as Healthwatch we are very grateful to it, because I think what it did for us was helped us to hear from people we wouldn't have heard from, and that was during the period of the project, which was really good. But I think the thing I'm really quite interested in now is the fact that we are running a multi-year project working with Northumbria Healthcare and Northumbria University to hear from people in Blythe and in Ashington around their experiences of persistent physical symptoms that don't get diagnosed. So it's quite a niche bit of research, really. But we have got people from Blythe who were involved with Heart of Blythe who have the confidence to come on and be our patient participation experts as part of that multi-year project. And I think you can really see where involvement with a project like this has enabled and helped people engage with us, because I think if we'd have done this sort of like 5-6 years ago or something, people might have been more suspicious because they wouldn't have known us. But we were able to build those relationships working with Heart of Blythe that has then gone on, and people have continued to have their voice heard, even though Heart of Blythe, as you say, is not there anymore. So I think that for me is probably one of the best things that's come out of it, is that real ability to engage.
You think that if there was another engagement on something, a public engagement session, you think people in Blythe are much more likely to engage now because of that? Well, that's definitely positive. Rob?
I mean, that's a fantastic example. I just wanted to explain some of the measures of success in Blythe in a positive sense. So when we started energising Blythe, 50% of the shops around the marketplace were empty. There was no positive use in the middle of the town centre for people to come and enjoy the town. There wasn't a reason to be there. That's why people said it wasn't safe. Fast forward 5 years on, we now have a town centre whose vacancy rate is significantly lower in that core area, and you now have something to do and a place to be and something to come together around, a stronger offer in the town centre. The target for the first year was smashed in the first 3 months of opening for the Market Pavilion. So as a measure of who's coming to that town centre and who's part of that town centre's future, I think that's a really good example. Blythe celebrates as the event programme alongside that. The launch event had over, I think, 8,000 to 10,000 people attended. It's probably the largest event in Blythe Town Centre's history, probably in the last 10 years. Underpinning that was the Heart of Blythe. The reason that has worked so well is because Heart of Blythe almost provided lots of easy access routes for people who don't usually get engaged. And like Councillor Chicken said, that work has continued. So Marine Medical Park, as an example, who participated in Heart of Blythe, ran an event on Christmas Day and are running an event this month on the darkest day of the year for people who are lonely and haven't got anything else to get involved in. And those are the types of events that have been created and a part of the Blythe Celebrate. You wouldn't normally think of a doctor's surgery as an event deliverer, and that confidence, I think, has come partly by these networks and the asset-based approach that Heart of Blythe has promoted. So they're hopefully some good examples of early success measures in Blythe.
Is there anything, just finally for me, is there anything that didn't work so well or learning for any similar projects? There always is, usually is something that you think could have improved on, learning for next time.
Yeah, I think it's quite hard to engage with the working age population who are out at work all day. We tried to do things in the evening and at different times, and that was quite hard. So it's almost like you've got like your core group, a lot of people who are older and people who are not working who were engaged, and you know that can help a lot with the inequalities angle. But it would be good to have that wider sector, perhaps who live around the edges of Blythe, to encourage them to, you know, be part of what's going on in the town centre and all the groups there. So I suppose it would be nice to have made more inroads into that. But I
think that was probably, I think I learned that, you know, it does take a long time to build trust, so you always think you're going to manage to do things quicker than you can, but I think in the end that becomes much more sustainable. And that was the beauty of this project, I suppose, is the Health Foundation allowed you that time to do all that discovery. We often like get money and like dive straight into it, but we actually had a lot of time to build those relationships. But yeah, and maybe a little bit more around involving residents in sort of maybe the you know, there's a lot of involvement in regeneration, but maybe more in planning and getting more involved in that process and having more of a voice in those sort of things that affect health and well-being in that broader sense. There's a few little examples of that, but it would be nice to have made more inroads in that. But you know, that opportunity is still there now because we do have staff there who can support residents to be more involved in decision making. So it doesn't mean it can't continue.
Great. Sarah, have anything else? Just want to thank you very much, Karen too on the screen, for that presentation. It'll obviously be something that we will keep an eye on in the future, because it would be really, if you, and the long-term benefits obviously take a while to see, but it would be useful to keep an eye on that moving forward. So over to Rebecca for the reports of the Scrutiny Officer and our forward plan of the work programme.
I'll keep it short and sweet. They're both just to know I have no updates, but just to reiterate, if anyone has anything that they'd like to add to the work programme, to get in contact with myself or Georgina.
Yes, please do it. Thanks very much. I know it's been quite a long meeting, but I thought it was very useful. Lots of good input and questions. So I'll see you at the next meeting on the 3rd of March. Thank you very much, and safe trip back.